Good afternoon, everyone, and welcome to today's webinar, Equitable Rebuilding from COVID-19, Ensuring Quality Care for Vulnerable Populations, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on the Network's website shortly after the conclusion of today's event. We strongly encourage attendee participation, so feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. Your moderator for today's webinar is Nicholas Terry. He is the Hall Render Professor of Law at Indiana University Robert H. McKinney School of Law, where he serves as the Executive Director of the Hall Center for Law and Health and teaches various healthcare and health policy courses. His recent scholarship has dealt with health privacy, mobile health, big data, AI, and the opioid overdose epidemic. He'll be leading us through the rest of today's webinar, so Nick, over to you.
Well, thank you, Charles. Thank you for your help in setting all of this up, and thank you out there for joining us. Our panelists were all contributors to two volumes, Assessing Legal Responses to COVID-19, published and available at publichealthwatch.org. Those reports were sponsored by the Center for Public Health Law Research at Temple University, ChangeLab Solutions, the APHA Law Section, and of course, the Network for Public Health Law. So our contributing panelists today, in the order that they will speak, are extremely distinguished and probably well known to many of you. Kason Schmidt is a research assistant professor at the Department of Health Policy and Management at Texas A&M University, where he actively researches how law impacts health information technology, including telehealth, health information exchanges, privacy, and confidentiality. Corey Davis is the director of the Harm Reduction Legal Project at the Network for Public Health Law. He's a nationally recognized expert on harm reduction law and policy. And in addition to his role as director of the Network's project, he serves as the deputy director for the Network for Public Health Law's Southeastern Region Office. Amy Judd-Liederman is a senior attorney with the Harm Reduction Legal Project at the Network and has worked on critical issues relating to the opioid epidemic and promoting harm reduction practices. And last, but no way least, is Jill Kruger, a director at the Network for Public Health Law's Northern Region Office. Her current work focuses on mental health and well-being promotion, climate adaptation and mitigation, and public health authority. So I'm really looking forward to these presentations, as I'm sure you are too. And so let me pass the baton to Professor Schmidt, and everyone enjoy.
Wonderful. Hello, and thank you to everyone for joining us. It is a true pleasure to speak with you today. Many thanks to the Network for Public Health Law and ASLME for hosting this just tremendously important discussion. I want to, let's start by defining telehealth. Broadly speaking, telehealth is the use of technology to support long-distance clinical healthcare, where healthcare provider and the patient are in different physical locations. Now, today, I'm going to use the term telehealth broadly, but you should know that states in the federal government do not have consistent terminology, and definitions can vary quite significantly even within a single jurisdiction. Now, telehealth is broadly promoted as a healthcare access tool. By connecting patients to distant providers, telehealth is particularly useful in rural and healthcare shortage areas, as well as useful to patients with transportation difficulties that prevent them from obtaining in-person care. Now, in the context of the COVID-19 pandemic, telehealth has transformed into a vital public health measure. The COVID-19 virus did not magically erase the existing endemic health issues, and it certainly exacerbated many. Patients with chronic conditions still need prescriptions, continuing care, mental and behavioral health issues still need attention and may be magnified by increased isolation. When preventative health care services are not utilized or they're accessible, the system is forced to respond to emergencies, progressive disease states, and as a result, skyrocketing costs. So in this context, telehealth is a tool to promote physical distancing to prevent COVID spread while enabling the delivery of healthcare services to patients. But in the age of COVID-19, we have an apparent paradox. Telehealth, a tool designed to address a critical barrier to healthcare services, may actually exacerbate inequities during the COVID-19 pandemic. The reason why has to do with how telehealth interacts with existing barriers to healthcare services and how telehealth actually introduces new barriers that are disproportionately experienced by already vulnerable populations. These effects were magnified as providers shifted heavily to telehealth services in 2020. So let's start by looking how telehealth compounds existing barriers to healthcare services. So steep healthcare costs and healthcare coverage are major barriers to health services. This is also true for telehealth. However, historically, healthcare payers and insurers have provided different levels of coverage and reimbursement for telehealth services as opposed to comparable in-person services. Now, many states have laws that eliminate these differences, and several states temporarily addressed these differences with emergency orders in response to COVID-19. But in some jurisdictions, these telehealth coverage differences remain. In addition, telehealth introduces new costs to a healthcare encounter, including costs for a telehealth capable device, that is, if a patient doesn't already own one, and high-speed internet sufficient to sustain the encounter. These challenges during COVID-19 have been compounded by the increased economic burden caused by this virus, and these challenges are disproportionately experienced among many vulnerable populations. Cultural competence is critically important to a successful doctor-patient relationship. It helps foster trust, and without it, patients will share less and may be more reluctant to participate in the treatment process. And without it, provider biases may cloud decision-making. But here, telehealth may actually offer some assistance. After all, telehealth provides a limited window into a patient's life that a sterile doctor's office does not provide. You may see certain facts and circumstances that might contribute, for example, to the disease state of a patient, or environmental factors that might contribute to the disease state of a patient. But still, telehealth increases the physical and emotional distance between the provider and the patient. This is especially true for those states that, in response to COVID-19, have legalized audio-only, so phone telehealth encounters. It makes it much more difficult to bridge that divide that might exist between providers and patients. So language barriers can also be massive. Now, while telehealth technologies can facilitate translation services into patient encounters, the trick for many providers who rushed to adopt telehealth services during the pandemic is that they need to develop those required workflows and processes for those translation services into the current environment where healthcare resources are strained and very limited. And so working those new workflows and processes and developing those can be quite difficult. Now, disability is also a critical healthcare barrier. Now, telehealth can be enormously helpful to persons with transportation or mobility challenges, but the disabled community has diverse and unique challenges, and a one-size-fits-all approach just cannot work for everybody. Moreover, and importantly, there are existing technological disparities in the disabled community. So telehealth may not be a good solution for many persons with disabilities. Now, those were all existing healthcare barriers that have different challenges in the telehealth context, particularly in the COVID-19 area. Next, I want to briefly discuss new barriers that are very specific to telehealth. So, telehealth has two primary entry requirements: having a telehealth capable device and having access to reliable high-speed internet. Both of these entry requirements cost money, and the dire economic conditions created by COVID-19 for many only make these costs more burdensome. Life-changing events precipitated by the COVID-19 pandemic can cut a person off from the internet. So loss of a job, an eviction, or closing a local library can mean the loss of a computer that is used regularly for online access. Emergency laws that reduce copay requirements help individuals without a telehealth capable device. But the cost of a new computer or a new smartphone is a much steeper entry requirement. So federal and state actions in response to COVID-19 sought to help technology access issues by authorizing new modalities or ways to engage in telehealth delivery, including audio only, so telephone communication as a telehealth encounter. Now, don't get me wrong, expanding telehealth services to include these new modes of delivery, they can be used by individuals with limited technology access. And this certainly helped persons access needed services who would otherwise be cut off from healthcare during COVID-19 restrictions. So some care is better than no care. However, governmental efforts authorizing inferior modes of telehealth do not fix the inequities that result from unequal technology access. Normalizing inferior modes of healthcare services like audio-only telehealth only bakes unequal treatment into the system for those with fewer resources. This will ultimately lead to wider inequities in healthcare outcomes. So, addressing the technology access barrier is an immense challenge in this COVID-19 pandemic. Some states have added new community resources, for example, publicly accessible library computers. But the flip side is that these create new opportunities for spreading the virus in the community. Now, federal individual stimulus payments can also be used to adopt or purchase the technology needed for telehealth, as well as, for example, remote work during the pandemic. But what we've seen with many of these stimulus payments is that they're probably too little to provide much more than basic sustenance for those that really need it. So food, utilities, and importantly, rent. And there's probably not enough there to buy something like a telehealth capable device or technology. Importantly, and more recently, the Consolidated Appropriations Act of 2021 created the Emergency Broadband Connectivity Fund and the Emergency Benefit Program. And these programs provide monthly discounts for broadband internet access and equipment during the COVID-19 response. But as a discount, these programs are meant to help individuals that can afford standard internet connectivity to upgrade to broadband. But they're not going to have as important of an impact for those who can't afford internet as an additional monthly expense. But still, the Emergency Broadband Connectivity Fund provides an important new tool to address these broadband access disparities. So digital literacy is another barrier to telehealth services that is disproportionately felt by some populations, particularly for the elderly, persons of color, and those with low socioeconomic status. So a new telehealth encounter, for example, might require that a patient become familiar with the provider's online patient portal to find the appointment details and instructions. Telehealth patients might also need to identify, download, and install and operate a new telehealth application. And this application might be different between different healthcare providers. As you can imagine, there are just a multitude of opportunities to create confusion and frustration for individuals who aren't tech savvy or have high digital literacy. And when patients have substantial technical difficulties, they can miss appointments. Appointments can be cut short, or they can be converted into something that's less than ideal. For example, just an audio only phone interaction. Since these challenges are disproportionately experienced within certain populations, continued reliance on telehealth as a dominant form of healthcare delivery risks widening inequities among these populations without adequate care or intervention. Now, accumulating evidence shows that COVID-19 disproportionately affects certain populations through increased health risk, as well as economic and social harm. Perhaps unsurprisingly, the populations that are hit the hardest by COVID-19 are many of the same populations that experience the most significant economic, social, and health inequities. These existing inequities and disparities contribute to barriers for telehealth services. The lack of education can contribute to a lack of digital literacy. Unemployment, underemployment, and low wages can limit resources available for telehealth capable technologies and high-speed internet. Consequently, the same populations that have the highest need for some healthcare services also experience substantial barriers to receiving these telehealth services. So as a result, telehealth's value as a tool to promote healthcare access is inequitably limited for many, many, many disadvantaged populations. So unfortunately, the data support this. Observing the changing telehealth patient populations before and after the COVID-19 pandemic, Nori et al. Found that and observed that the rates of telehealth use actually decrease for certain populations, particularly people of color, the elderly, Medicaid and Medicare recipients, and non-English speakers. Now, undeniably, telehealth promotes healthcare access. It reduces costs and it promotes this physical distancing that we really need to slow COVID-19 transmission. But it does this for individuals who have telehealth capable device. They have access to reliable, high-speed internet, and they are digitally literate. However, here it comes, right? Telehealth has clear entry requirements. And to the extent that patients bear the burden of these entry requirements, telehealth will remain a tool for the privileged. So, and this is particularly problematic when we see those with existing disparities and these disparately felt telehealth access barriers converge, right? This is where we can expect that to see these widening inequities. So what can we do about this? There are a number of things that we can do. And I think one of the important and perhaps untapped resources, well, definitely untapped resources, are community health workers. These are individuals who more often than not are untrained, or they are trained, sorry, they are lay persons, right? And they have a deep understanding of the communities that they serve. And they use this intimate understanding to bridge gaps between providers and patients. And using and leveraging this underutilized, tremendously beneficial resource to promote telehealth training and education, particularly for vulnerable populations and those populations where we can expect these telehealth burdens to be inequitably experienced, it could make a huge difference. I think we should also have a greater investment in technology and broadband subsidies particularly for high utilizers of Medicare and Medicaid programs, and also vulnerable populations. Now, we've seen this in the Emergency Broadband Connectivity Fund, but I think more can be done, particularly since that fund is limited. And if we want to truly address telehealth as a tool to promote healthcare access, then we have to acknowledge the fact that its own barriers to use will create or endure as a lasting barrier unless they are addressed in a systemic way. And lastly, I think it's very, very important that the federal government particularly monitor the inequitable outcomes associated with different telehealth policies and practices as we've seen those implemented in the various states. I want to note too that there is a fiscal argument for investments of these sorts. And this argument is particularly strong for patients with chronic conditions and high utilizers of healthcare services. During the COVID-19 pandemic, where many health conditions may be neglected as a result of the current difficulties, for example, economic difficulties, physical distancing, there's a fiscal argument for investments that will help to get these patients preventative care so we can avoid more expensive, more complicated disease states in the future. So thank you for bearing with me. If you have any questions, I'd be delighted to answer them at the end. I'd also welcome any email comments or questions. You see my work email here. If you'd like for more information, please see the published reports as well. There's plenty more there. Thank you so much. I appreciate it. Oh, it looks like I may have forgotten to advance to the last slide. There you go.
Hi, I'm Amy Lieberman with the Network for Public Health Law's Harm Reduction Legal Project. And Corey Davis and I today are going to be talking about access to care for individuals with opioid use disorder. A little bit of background. Currently, we have 2 concurrent public health emergencies in the United States. Nearly 88,000 overdose deaths were reported in the United States in the 12 months ending in September 2020, more than any 12-month period prior. 52,000 of those due to opioids. The opioid crisis declared in October 2017. On the other hand, we have COVID-19, where over 580,000 people have died from COVID-19 in the US. The public health emergency was declared in January of 2020, and the national emergency declared in March 2020. There are some similarities between these 2 epidemics, and both disproportionately harm already disadvantaged groups, as Kasim was talking about in the telehealth section, and both have been made worse by lack of access to evidence-based interventions. Some more similarities and differences, and now that we have vaccine, more differences than similarities, but there are the non-medication prevention and treatment recommended for COVID-19, wearing masks and social distancing. However, on the other hand, that lack of social interaction and access to services can increase the risk of drug-related harm and overdose. Medication prevention and treatment for COVID-19, we all know we have a free vaccine. The availability of that vaccine varies by location, but generally very good at this point. Whereas we have evidence-based treatments for opioid use disorder, opioid agonist treatment with methadone or buprenorphine, there are many barriers to access for those medications, even though use of them reduces all-cause mortality by about 50%, and they reduce overdose, risky drug use, and relapse. Unfortunately, many people who want to access these common sense, life-saving services are unable to for a variety of reasons. But today we're going to talk about those that are mainly due to law and policy. Barriers to buprenorphine include the fact that until recently, very recently, most providers needed to obtain a federal waiver to be able to prescribe buprenorphine for opioid use disorder. It required 8 hours of training for physicians, 24 hours of training for other prescribers, such as advanced practice nurses. There's a cap on the number of patients that waiver providers can treat, starting as low as 30 patients. And the Ryan-Haight Act generally requires an initial in-person consultation before issuing controlled substances prescriptions, including for the treatment of OUD. That in-person access can be mollified with telehealth, but over, approximately 25 million people lack broadband access. That lack is concentrated among low-income people, people of color, and people in rural areas. Oh, I said something think the same. Okay. As you can see by this map, the treatment inequity by county level capacity to provide buprenorphine, there are not a lot of providers in the areas that are most hard hit, especially in rural communities. Barriers to methadone are even more restrictive. Only federally certified opioid treatment programs, or OTPs, may dispense methadone for opioid agonist treatment. Only patients with certain characteristics are eligible. Prospective patients must have an initial in-person visit. Those initial doses are limited despite the amount of opioids that the person was using prior to methadone treatment. Periodic urinalysis required. All patients have to come to the OTP daily. At first, take-home doses are only available per federal schedule and not provider expertise or patient characteristics. State laws often impose further limitations, like the limitations on numbers of OTPs or the burdensome and unnecessary showing of support from the community. And local laws often restrict the citing and other restrictions. For example, Georgia allows no more than 4 licensed MMT programs within each region of the state, and Indiana requires that OTPs demonstrate strong community support through letters from interested community members. West Virginia, which has the highest drug overdose rate in the country, and the CDC has flagged as a place of as the most concerning HIV crisis in the country, has a blanket moratorium preventing the establishment of any new OTPs. And these restrictions matter. Despite the fact that they reduce harm, methadone and buprenorphine for opioid agonist treatment are much more restricted than nearly any other medication, including the same medications when used for pain. Only about 4% of US physicians were waivered to provide buprenorphine in 2016. About 40% of counties have no waivered provider, and somewhere around 75% of people with opioid use disorder received no treatment in the past year. Majority white counties are more likely to have buprenorphine providers. Majority Black counties more likely to have methadone providers. And as you can see, the average travel time to an OTP is about 20 minutes, to a pharmacy, 4 minutes. It'd be a lot easier to be able to pick up your methadone from a pharmacy. And you can see as you get further away from the cities, that time becomes much greater. And in fact, in non-metropolitan counties, it can be anywhere between 48 and 60 minutes on average to access an OTP. Now I'm going to turn over the presentation to my colleague, Corey Davis.
Right, thanks, Amy. So we wanted to talk about a couple of temporary changes to accessing opioid agonist treatments, buprenorphine and methadone, for opioid use disorder. Now, I would say kind of interestingly and surprisingly to myself and a lot of other folks in this world, the federal government did act relatively quickly and relatively robustly early on in the COVID crisis to rescind some of the more severe barriers to opioid agonist treatment. So I want to go through them in turn quickly and then talk about how we might continue to remove these barriers to these evidence-based and life-saving treatments. So first, buprenorphine. As Amy said, buprenorphine barriers are somewhat less than those for methadone, but they are still, loom large in the lives of people who are trying to access buprenorphine. A big one of these is actually a barrier that exists beyond buprenorphine, but falls particularly heavily on people trying to access buprenorphine treatment. And that is this law called the Ryan-Haight Act. It says that in general, a provider can't first prescribe a controlled substance to an individual without first having an in-person medical examination. Okay, so that is one of these things that is probably generally a good idea, But in the context of buprenorphine, particularly in the context of a pandemic that's spread by person-to-person contact, it's a real barrier. So there is a kind of safety valve in that law that permits the HHS secretary, in consultation with the attorney general, to waive that requirement. And HHS did that relatively early on in the pandemic. Now, initially, they said, okay, you don't need to have that in-person examination, but you can have a telehealth examination. Now, as Kaysen said, telehealth and telemedicine have various definitions in various places in federal law and in even more varied in state law. But they initially said that you need to have a real-time audio-visual communications consult. This is sort of the traditional Medicare definition. As Kaysen said, obviously this is a big barrier. A lot of people don't have the ability to do that, don't have a smartphone, don't have broadband, and so on. I'm going to talk a little bit more about that in a second. DEA enforces the Controlled Substance Act, enforces the Ryan-Haight Act, and can just say, look, for the duration of the pandemic, we are not going to enforce that requirement. Until we say you can't, you can do that initial consultation through just a regular telephone call. And that has been really important. So that is, been done totally at the sub-regulatory level, right? No statutory change, no new regulations, just federal officials getting together and kind of doing the right thing in an emergency. DEA has also changed a couple other sub-regulatory limitations. So they have waived, in some instances, this requirement that each provider be registered in the state in which the patient is located. This is one of those things that is sounds like maybe a obscure regulatory requirement, but is actually really important in the telehealth context, right? Because if you need to be registered with the DEA in each state where you're seeing a patient, that limits your ability to provide care via telehealth, particularly if you're in a town near the border between states or something like that. The Office for Civil Rights in HHS has also said that they are not going to enforce good faith violations of HIPAA in conjunction with efforts to provide telehealth. Now, it's not clear exactly what that means, but it does seem to be kind of a we know it when we see it sort of thing. That if a provider is doing the best they can, but potentially violating HIPAA by, for example, not utilizing a telecommunications platform that is certified to be HIPAA compliant, they don't need to worry about HHS coming after them for those sorts of, de minimis potential violations where there was no intent to defraud, where everyone is trying to do the right thing. Again, just the kind of sub-regulatory guidance that can be very helpful to encourage providers to do the right thing, okay? And, all of this taken together has been really helpful to help places initiate and continue called telebup, these telehealth initiated buprenorphine projects where people can just call a hotline, call an 800 number and say, hey, I would really like to get started on buprenorphine. They can talk right away to a provider who can, do an assessment over the phone. And if the person is appropriate for buprenorphine treatment, prescribe buprenorphine right over the phone, then the person can go to the pharmacy, get their buprenorphine, and then they're linked to follow-up care, right? Then they are linked to a traditional provider. And this has been working out pretty well in a bunch of places. And again, not to beat this horse, and I'm not sure whether Kaysen and I disagree on this or not. It may be a perfect and the enemy of the good sort of thing. being able to access that initial buprenorphine appointment via the telephone has actually been, really, really helpful. There are lots of people who are calling the hotline who said, like, I've wanted to do this for a while, but, I couldn't make an appointment, or it's hard for me to get to the appointments, or, I don't have minutes on my phone, or somebody stole my phone, or I don't have a phone, or I don't have broadband, or whatever. It is, smartphones are so ubiquitous amongst, us, sort of higher income folks that we sometimes, it doesn't, we need to keep in mind that lots of people in rural areas do not have broadband. Lots of people who maybe make less money than we do not always have a smartphone that's charged, that has minutes, in their pockets. So just being able to have a regular phone call, I agree, maybe not the quite as good as being able to see a provider in person, but certainly much better than not seeing the provider at all. So telephone only, very good thing compared to the baseline of not seeing a provider at all. So also some important changes in the methadone world. SAMHSA, which is the federal agency that in conjunction with DEA oversees methadone maintenance treatment, has changed this huge barrier, which is that generally speaking, people who are starting methadone treatment, and for quite a while after they've started, need to come to the methadone clinic 6 days a week, right? Line up in the morning, wait in line, go through this, somewhat, dehumanizing process of like watching somebody, having somebody watch you take the medication, through a window, very sort of like, it reminds me of like, sort of these movies from the 80s, about that sort of show like, how bad it is to be a person who uses drugs. I mean, that really is the model of the methadone clinic in a lot of places to this day. And that's because federal law requires that people come in every day. Obviously, federal law doesn't require that it be so dehumanizing, but a lot of these places really are like that. Anyway, SAMHSA waived that requirement, said almost everybody can get 2 weeks of take-homes, and stable patients can get 28 days of take-homes, which is just like, for people who aren't in this world, I mean, like, there's just such a seismic shift that people have been pushing the federal government literally for decades to just sort of make it a little easier for people to get take-homes. And they've refused for decades. And, COVID comes, and suddenly just with some sub-regulatory guidance, SAMHSA said, actually, it's fine now. Almost everybody can get 2 weeks. I mean, this is really good. This is good, and kind of shows just the, I don't know what the word is, the ability of federal officials to be responsive when they want to be. DEA has also made a couple of other little changes, permitting some sort of offsite dosing without the offsite location going through the regular permitting process, permitting some methadone delivery, which was generally forbidden before. Of course, all of this stuff has to be operationalized at the state level and at the facility level. So these are, this is the federal government is saying you can do this. A lot of states have their own restrictions, either in statute, regulation, or sub-regulatory guidance. They need to change that so that people can actually, access methadone the way the federal government is permitting them to. States are kind of all over the map on how they're doing that. Unfortunately, they're, although they can, to be clear, SAMHSA can, in conjunction with DEA, can waive the requirement that people have an initial consultation at the OTP before beginning treatment, the same way they can waive the take-home requirements. They have not done that. So to initiate methadone treatment, you do still need to have this kind of lengthy evaluation at the OTP. Now, the thing is, so this is all good stuff, right? Like, this is getting us closer to where we should be, right? Where it's not significantly harder to access treatment for opioid use disorder than it is to access treatment for any other condition, right? Because that was the status quo before, right? If you want, you've got a stomach ache or you've broken your arm or something, it's relatively easy, putting aside the transportation barriers and financial barriers and so on. The federal government has not passed laws making it purposely more difficult for you to get your stomach looked at, the way they have, to make it purposely more difficult for you to get treatment for substance use disorder. So so these changes have kind of rolled that back just a little bit, but they are all tied to the COVID emergency declaration. So when that thing expires, all of this goes back to status quo, right? So what should we do? Well, we should make these things permanent, okay? We should make these things permanent. The crisis of drug-related harm, particularly opioid-related harm, was, terrible before COVID. It's even worse now. When COVID clears, it's still going to be there. So there's no reason to go back to the status quo. We can do it a couple of ways. The best way from a standpoint of sort of lasting legal change is to pass a law. To repeal these restrictions that make it more difficult to access opioid use disorder treatment than treatment for other conditions. I won't belabor that point. That's sort of self-evident. I will say that there are some laws kicking around on the buprenorphine side that would make it easier to do these sort of telehealth consultations. As of now, they don't include the telephonic consultation permission. I think, and providers and patients that I've talked to think that is really important. I agree that it would be better if we just make sure that everybody has transportation to appointments and that there are enough providers that everybody can see one, and everybody has the financial means to see a provider. I agree, that's where we should be, but we're not there. Until we, while we're working towards that, it would be great if people could pick up the phone, talk to a doctor or other provider, and get the care that they need. You can also do this through regulatory change. Most of these things that we talked about are actually in regs, not in statute. A lot of the specific nuts and bolts are devolved to the agencies. Agencies could extend most of these things indefinitely through regulation. I would say there is one good change that we've seen recently, which is SAMHSA has changed sort of this waiver requirement for buprenorphine providers. Like Amy said, now if you want to prescribe buprenorphine, you not only need to be a physician or certain other providers, but you also need to go to an 8-hour training if you're a physician, or 24-hour training if you're other providers, and get what's called an X number, an X waiver. SAMHSA has now said that many of these providers can now get that X waiver to treat up to 30 patients at a time without going through the training. So this is a step in the right direction, and this is permanent. This is not tied to COVID, right? So this isn't where we need to be, but this is an important change, and we hope to see more of that. Of course, like I said, state and local governments need to change their restrictions as well. Lots of states, like Amy said, and other localities like to play games with zoning and other things to try to keep these, to try to make it more difficult for people with the medical condition of opioid use disorder to be able to access the treatment for that condition. That is what states and localities have done, and they should knock that off. Really wanted to really quickly talk about diversion. This is the pushback against this. Well, what if people are getting buprenorphine or methadone, outside of the traditional medical system? And the clear answer to that is, well, that means that we need to expand access to the traditional medical system so people can get it from a doctor, right? Or a physician assistant or nurse practitioner, whoever. It might be. People are, getting this stuff on the street because they are trying to treat their opioid use disorder. If you want to get rid of that diversion, what you want to do is make it easier for people to access it through the traditional system, not harder. So with that, I'm going to turn it over to Jill.
Thank you, Corey. And yes, thank you to Corey and Amy and Jason and Nick and Charles. And I'm glad to be here with all of you. Thank you for being here. And now I'll be shifting the discussion a bit to discuss legal strategies for promoting mental health and well-being in the COVID-19 pandemic. And as my fellow presenters have suggested, of course, COVID-19 is not the only pandemic or national emergency that we're undergoing as a country. There's a racism pandemic, the opioid epidemic, climate change, which I won't touch on too much, but it's part of, I think, the context as people are striving to flourish in terms of their mental health. So just a broad outline of what I'll be talking about. At the network, we tend to think about mental health and well-being in four broad categories. And I'll touch briefly on two of them, meeting basic needs and violence prevention, but spend more of my time focusing on improving and expanding access to care and supporting relationships and teaching skills. So I wanted to begin with a reminder, we have plenty of anecdotal evidence from our own life experience and the lives of those around us to know plenty about the mental health impacts of the COVID-19 pandemic as well as the other pandemics. And there is a risk of pathologizing these entirely normal reactions to really terrible and abnormal situations. So, and we can see, a cumulative toll of these circumstances, just in terms of exhaustion as we round the corner, having completed a full year of the pandemic. There's hope on the horizon, and that's really important as the vaccine rollout continues. And that's critical in terms of trauma response and psychological resiliency. So highlight that as well. Now, in terms of data, one of the struggles I think sometimes with mental health, as with many areas of public health, is the difficulty sometimes in accessing timely data. So one of the things that has been going on for most of the past year has been a collaboration between the CDC and the US Census Bureau, which has been a telephone survey, the Household Pulse Survey, that really has sought to collect data related to the prevalence of anxiety and depression, and compared with, and this is some of the data you would often see cited in media accounts, for example, and compared with the data from 2019, where there was a prevalence, even combined, of anxiety and depression of about 10%, we see that just across the population, those rates of anxiety and depression are elevated, frequently above 30%. Really, and there are breakdowns in terms of gender and age and race and ethnicity, but really one overriding, and there are differences, particularly related to race and ethnicity, but just across the board, there are just population level effects that it's important to be aware of. And then another place where we see profound impacts are particularly among teens. So the Mott Foundation conducted a poll and just found, now this is a poll actually of parents noticing a new problem or worsening of existing problems, but just, again, profoundly elevated mental health concerns among teens. And there was also an MMWR report in the fall noting that after an initial decrease when community mitigation measures first were implemented, there was a rise in the rate of teens using the emergency room for mental health, to address mental health issues. And that's an important indicator, both of lack of access to more routine mental health care and of circumstances or a rise in overall circumstances, environments that are contributing to mental health concerns and challenges with mental health. Similarly, as early as last summer, the CDC reported in MMWR a rising concern about suicidal ideation, particularly in that age bracket from 18 to 24 years. And it might be related to closures of colleges and universities, difficulty in finding entry-level positions, or closures of businesses with those entry-level positions. Some of them may or may not have been able to be translated to remote work, and some of them may have in fact not had closures. So many of those individuals may have been essential workers with concerns about the risks they were taking, the risks they might have been bringing home to loved ones. Now it's important to note that suicidal ideation is not necessarily directly correlated with suicide attempts or suicides. So far, there's fairly limited evidence of any spike in suicides over the last year. Some of that data is still being collected. But in any case, suicides were at the highest point really in decades prior to COVID, so that they have not elevated further is somewhat reassuring, but also I would suggest that this is something that we need to continue to pay attention to as mental health concerns arising from, whether it be a natural disaster or a public health emergency. Those concerns can have a long tail and show up months and years later. So it's something to continue to pay attention to as we'll be discussing. So I mentioned that I won't discuss at length this strategy for addressing mental health that involves meeting basic needs because it's covered in other chapters of the COVID policy playbook. But certainly, probably most people on this call are familiar with the social determinants of health. And there's a lot of thinking to suggest that those social determinants of health are also social determinants of mental health. And again, many of these are being addressed in the other chapters. A couple of things I did want to highlight. Recent work by Rakaya Yerby suggesting or making the case that racism is a fundamental driver of these social determinants of health. And also recent work over the last number of years by Wendy Ellis at George Washington University, making a case for what she calls the pair of ACEs that, and we'll talk later about ACEs further, adverse childhood experiences, that in addition to looking at she calls it the pair of ACEs, that we need to look, understand the impact of both adverse childhood experiences and adverse community environments, which again captures the notion of these social determinants of mental health. But turning to access to mental health care, there are a number of strategies that we can think about in terms of increasing access to mental health care. We've discussed some of them. Kaysen has given us a lot of information about telehealth, both the improvements that have occurred and some of the remaining barriers. I'll focus primarily on COVID relief legislation but touch on some of these other aspects of strategies to increase access to mental health care, or happy to discuss further in the Q&A as well. So back in the early days of the pandemic, Congress passed the CARES Act and made some initial modest investments in mental health care with things like certified community behavioral health clinics. Now these are still somewhat in the pilot stage or the demonstration stage. They're not available in every state yet, but they are places where there can be an integration of mental health care and primary care. And so that was one place that Congress chose to make an enhanced investment, as well as dedicating resources to emergency response by states, suicide prevention, tribal communities, care for veterans, and some initial thought to expansion for school mental health services and funds to address the needs of low-income students and students of color. But again, not a great deal of policy innovation and not an enormous investment, but some recognition that there would be a mental health component to the pandemic at that early stage. Now, by last December, when Congress was passing the Consolidated Appropriations Act, including the Coronavirus Response and Recovery Supplemental Appropriations Act, or CRSA, there was a much more profound awareness of the mental health impacts of the pandemic as the pandemic had continued over months. And so in addition to the baseline investment and funding for SAMHSA, which is roughly $6 billion, there was a separate cluster of funding, also funneled largely through SAMHSA, but that was over $4 billion. A lot of that was funneled through the Substance Abuse Prevention and Treatment Block Grants, Community Mental Health Services Block Grants, and again, the Certified Community Behavioral Health Clinics. So this is funding that is being made available largely through the states, as SAMHSA is essentially a pass-through. But this is a pretty historic investment by the federal government in mental health, focused largely on treatment of serious mental illness, although there is language in SAMHSA's strategic plan about focusing on the full continuum of benefits and strategies to address substance abuse and mental health. So including prevention and education and workforce training and the like, as well as direct care for individuals. So that's a critical expansion and commitment to mental health that we do see in the Consolidated Appropriations Act. Now, the focus really has been, given the emergency footing and for whatever other reason, there hasn't been, again, a great deal of policy innovation at the federal level in terms of mental health. There's a much appreciated and much needed investment in a chronically underfunded system, but there isn't a great deal of policy innovation, except for that last bullet, mental health parity compliance in regard to non-quantitative treatment limitations. Now, to date, much of the attention with respect to mental health parity requirements under the Mental Health Parity and Addiction Equity Act, which really, essentially, to boil it down, requires healthcare providers, to the extent that they cover physical health and provide medical and surgical benefits, to provide comparable benefits for mental health. Now, implementation and enforcement of both federal and state laws related to mental health parity have been challenging. One step forward in the Consolidated Appropriations Act is to look beyond quantitative requirements, such as comparisons of visit limits for both medical or surgical care, mainly medical care, and mental health care, to now look at quantitative treatment limitations, things like pre-authorization requirements. That you can't make the pre-authorization requirements for mental health more strict or more onerous or burdensome than the similar requirements for medical treatment. And the way that that's being rolled out is with a mind toward implementation. So the requirement under the Consolidated Appropriations Act is that health insurance providers and group health plans are providing reporting and analysis, comparing their treatment limitations for medical and surgical care with their treatment limitations for mental health care. And then the federal agencies such as DOL and HHS are to do at least some review of those plans, some portion of those plans, and provide an annual report to Congress. Okay, so the American Rescue Plan Act is in many ways similar to the Consolidated Appropriations Act, provides additional funding for the substance abuse prevention and treatment block grants and community mental health service block grants and certified community behavioral health clinics, as well as provider relief funds for those healthcare providers, particularly who may be providing care under public programs such as Medicare, Medicaid, and CHIP. Now, there's an additional set of priorities under the American Rescue Plan Act that have much more prominence than in prior legislation. And that's really focused on the emerging problem as the American Rescue Plan Act was being formulated of fatigue, exhaustion, burnout among healthcare providers, mental health providers, first responders, and the like. So this last set of bullets is really focused on strategies, funding to support strategies by healthcare systems, by states, by local governments, to support their workforce, to help them essentially make meaning out of what has happened over the last year, integrate it into their life experience, and experience growth as they grapple with all of the challenges over the past year. So those are really a really important new set of at least funding priorities under the American Rescue Plan Act. One last point, much of what I've seen in the COVID legislation has really flowed through SAMHSA. But one point that's been made by Mental Health America and the Wellbeing Trust in this recent, I believe it was December of last year, this report about the use of EPSDT for children's mental health, arguing that the Medicaid benefit, especially early periodic screening, diagnosis, and treatment for children's mental health, is underutilized and may, in some cases, in fact, not be in compliance with federal law in terms of the types of services that are required to be provided. Though the report also notes that federal funding is not adequate to provide those services. So for those who are administering state Medicaid programs and looking for strategies to expand the support for children's mental health, this report may be a valuable resource in terms of looking at what states are doing, as well as suggesting strategies for advocates to urge increased funding and greater attention to children's mental health in the Medicaid program, particularly to achieve guidelines, achieve compliance with clinical guidance. Okay. So we want to make sure we have plenty of time for question and answer. So a third strategy for addressing mental health and well-being is violence prevention, and that can include suicide prevention, gun violence prevention, preventing domestic violence, and child abuse. One thing that I particularly wanted to lift up in our discussion, and that my colleague April Shaw has been working on and will be releasing future resources in the coming months, has to do with the rollout of a new national suicide hotline 988 that will be complete, is targeted to be completed by July of 2022. So that means many states are already beginning that transition planning process. There's legislation moving forward in a number of states, all of which is because having this 988 number will provide an identifiable pathway for mental health crises that have otherwise been routed through 911 and frequently referred to law enforcement and related to concerns about police violence and systemic racism related to law enforcement. This provides one important law and policy strategy to both get more effective mental health treatment of mental health crises and minimize structural racism. Okay. So one final strategy that I want to spend the last few minutes of my presentation on has to do with supporting mental health knowledge and skills that in terms of, as with public health generally, with mental health, prevention is really at the core of what we want to do. We certainly want to increase access to care, particularly for those who have been denied equitable access to care, communities of color and low-income communities. But prevention, in terms of the ability, the potential to prevent depression, anxiety, post-traumatic stress, and the like, is quite significant, and to minimize the lifelong health impacts, physical and mental health impacts of adverse childhood experiences, the potential is great. So there are three core principles that the Center on the Developing Child at Harvard University articulates, I think, quite nicely. And that has to do with reducing sources of stress, i.e. addressing the social determinants of health, supporting supportive relationships, and strengthening core life skills. And I think that's a helpful model, not just in early childhood, but as we look forward through the K through 12 system, university and colleges, and throughout the lifespan. This was, I thought, a nice resource that the Indiana Department of Education created to provide guidance for their school districts who might not have time to comb through the CARES Act, but really lifting up a number of kind of types of support that might be found in the CARES Act, including that fourth gear down, support that could be accessed through the CARES Act for social and emotional learning, which can, again, support both the educators and other adults in a school environment in developing their skills, because the evidence is that when the adults are in charge of, have mastered their own self, are able to regulate their own emotions, they're much better able to support the students in their class. So I thought that was a nice resource that was created by the state of Indiana. And CASEL, the Collaborative on Academic, Social, and Emotional Learning, has produced a variety of helpful resources about how states and individual school districts can support mental health, both in remote learning and as schools return to in-person learning. Now, again, many folks are familiar with adverse childhood experiences. Increasingly, this is a resource from CDC, we're understanding that adverse childhood experiences both have an impact up the pyramid in terms of social, emotional, and physical health, but also are themselves impacted by the environment and the history in which people are located. Just briefly want to highlight some of the activity at the state level. The state of California and their Surgeon General, Nadine Burke-Harris, produced a 400+ page report last fall, Roadmap for Resilience, taking really a whole of government approach to how can we become a trauma-informed state. So I really commend that report, or at least the executive summary, to you. There are certainly a number of other states working in a parallel track. The state of New Jersey has issued an ACEs action plan. Pennsylvania has a trauma-informed Pennsylvania plan. The state of Wisconsin has been working toward becoming trauma-informed for quite a few years. So there are lots of models to be accessed for states that may be ready to consider integrating a response to ACEs and a preventive approach to mental health promotion and prevention of mental illness. Finally, many people are certainly aware of the phenomenon, the wave of declarations of racism as a public health crisis that began last summer, particularly following the murder of George Floyd by Minneapolis police. The Hogg Foundation in Texas also has suggested that one might make a declaration of racism as a mental health crisis. In any case, these declarations can be tools for addressing things like trauma and adverse childhood experiences. So suggest those as valuable tools as well. Becoming a trauma-informed health department, in addition to those resources and the funding available through HRSA under the American Rescue Plan Act, there's certainly resources through the National Child Traumatic Stress Network, the Hospital Preparedness Program. There was a useful study, partly informed by the Illinois ACEs Response Collaborative, as well as a consultant, that did an environmental scan of trauma-informed health departments that has just a wealth of rich examples from the local level. Collaborative health departments in the San Francisco Bay areas have been working on really becoming a trauma-informed and healing health department. And that may be, I suspect, of interest to a great number of health departments, again, as the public health workforce is grappling with its own, well-being and integrating the experiences of the last year. All right. So we'll turn it over, I think, back to Nick. Oh, I did want to, I didn't create a slide, but I did want to share then, draw out from my presentation just a few recommendations. One is to increase Medicaid funding, specifically for children's mental health. I think that early data that we've seen shows that there's a need, that it will serve those who have the least access to mental health care. As we are implementing the increased funding for the long-standing SAMHSA programs, there will be a need to monitor those programs and to provide feedback to ensure that, in addition to providing enhanced care for serious mental illness, they are addressing that full continuum of both prevention and treatment for mental health. Continuing to use declarations of racism and to ensure that those are used not simply as statements of goodwill, but there are, flesh on the bones, that there are data being collected, implementation measures being identified, accountability being instilled as those declarations of racism come to life. And finally, addressing ACEs and trauma, both in the general population, among the public health and healthcare workforce, and in the schools. All right, then I'll turn it over to Nick.
Well, thank you to all of our panelists for some really powerful presentations and their identification across these three domains of the urgent need to normalize access and treatment. Let me start with a question from Chris for Payson. Couldn't some of the burden of outfitting patients with the necessary technological packages, the successful telehealth interactions, couldn't those costs be passed along to the healthcare systems and insurance companies that presumably will benefit fiscally from these interactions?
I agree 100%. I think that is absolutely correct. And I'm not an economist, so I couldn't play those numbers out for each of those types of organizations. But I do think you're absolutely right that there's a very strong argument that many of these private institutions should be looking at these types of expenses as investments, a way to reduce costs from some of the patients associated with the patients that use a lot of services that could be prevented through increased telehealth services. Yeah, and oh, I'm sorry, were you about to say something? Oh, I love the point that Corey put forward earlier about the offering telehealth services in alternate formats, like telephone. And to be absolutely clear, I am strongly for any service that can be provided equivalently in any format. I think those should be made to make healthcare more accessible and convenient for those that need it. The thing that worries me a little bit about some of these expansions of telehealth modalities is that people might mistake them as solutions to inequities, when the real danger is that we might be creating a system where those with privileges can obtain better healthcare services through better modalities, and those without those resources, perhaps those that need the services the most, are left with differential or different and lesser forms. So I think there's a real caution there, and there's a very delicate balance. I think the question we always need to be asking ourselves is, can we do more to address the inequities? And so I think that's something we need to continually challenge ourselves.
Amy, you and Corey obviously identified things like the new buprenorphine practice guidelines that removes the waiver certification requirements for physicians and most other clinicians, and that's a major step forward. But the rest of these temporary improvements are going to expire at the end of the emergency, if the emergency ever comes to an end. At the moment, the HHS health agencies or offices are transitioning to new leadership. What are the best strategies here to get them to engage them on the idea of normalizing treatment?
I'm not sure Corey would have to say about this, but I think that showing whatever data we can gather from what's happened over the past year with the increased access and decreased restrictions on receiving this treatment will be helpful. And with the loosening of the X waiver, which is not tied to the COVID emergency, we can see that they're already taking some steps in the right direction, and hopefully that trend will continue. Corey?
Yeah, I mean, no, go ahead.
No, I was going to say, please add to that, Corey, if you want to.
Yeah, I mean, I think that it's almost like a baseline problem, right? I mean, we are, we're kind of assuming that the status quo was the right way to do it, and I think that all of the evidence shows us that is not the right way to do it. That there's really no empirical and certainly no ethical basis for making it harder to access treatment for opioid use disorder than treatment for other conditions. So we should consider this to be the new baseline, right? Or even, we should consider parity to be the baseline, and we should make people affirmatively, show the, health basis and the ethical basis for making it more difficult for people with certain conditions to access treatment, which is, the sort of traditional regime for OUD treatment.
So Jill, I could ask this question, I think, of everyone here on the panel, but I'm going to direct it at you. I think part of the challenge in improving access, specifically with regard to mental health, is sort of demonstrating the need in a timely way. How are we doing on mental health surveillance and data sharing about mental health conditions that would help generate improved access and treatment?
Oh, thanks, Nick. Well, I think we're making progress. There's still a ways to go. CSTE, the Collaborative of State and Territorial Epidemiologists, has been working for a number of years on developing a set of mental and behavioral health indicators that we're seeing state and local jurisdictions adopt. We're seeing, the evolution of measures of health-related quality of life to be, just a simple 4-part test. The BRFSS has had an optional set of questions related to ACEs that most states have used at least once in the last decade or so. It would be great, I think, for all states to use that set every year. And then we see, certainly healthcare systems working on collecting data related to ACEs to inform treatment, not collecting the data for the sake of collecting the data, but to inform treatment strategies. The network has been working with the Public Health Informatics Institute around data sharing related specifically to children and mental health, and has produced some resources in that regard, and we'll have more forthcoming in the coming months and years, I imagine. So we're making progress, but we're not there yet.
So there's a question from April, which is pointed at Kason, but I'm going to slightly modify it and ask you each to just respond in 30 seconds because we're literally coming to the end of this conversation. And the question was, is there evidence that patients experience telephonic, and I'm going to add telemedicine care, as inferior care? And I wondered how in each of your spaces you would answer that question or deal with, more generally perhaps, with the question of quality in mental health, in substance use treatment, or just generally. Kason, let's start with you with your 30 seconds as to telehealth generally.
Well, in telehealth generally, especially the empirical evidence on the real-time video communication shows that telehealth can be very high quality and cost savings healthcare services. The point I was trying to make about telephone related teleservices is it takes a lot of tools away from providers. When a provider enters a room with a patient, they rely on visual signs and symptoms to help inform that care. And importantly, it deprives the healthcare provider of some of the information they would be getting and some of the relationship that they may. Let me rephrase it. It increases the cultural competence challenge. It makes it more difficult for patients and providers to connect and build trust when there is increased distance provided there. And maybe I'll just, for time, leave it at that.
Amy or Corey, or both?
Yeah, just quickly. I mean, I don't disagree with that, but I think that it's a both and, right? I mean, like I said, we don't want we don't want a preferential option for the rich, right? Which is what we have now. If you have transportation, if you are able to get an appointment and make it, and your job will give you time off and so on, like, yeah, you can go see the provider in their office, and for some things that is probably a superior experience, but right now the option for people who can't do that is they don't see the provider, right? So telehealth is an improvement in the lives of those people, and telephonic can help some people access care who would not otherwise access care, people who don't have broadband, who don't have a smartphone, etc. Does that mean that they should not have the same, access to the same experience as upper class people with desk jobs? Of course not, right? But that's a good starting point. That's how I see it.
Jill?
And just a quick say, and in our specific field, when we're talking specifically about being able to access medication for opioid use disorder, if you are seeking treatment, the telephone is all that you need to be able to tell the provider, please get me a prescription.
And in terms of, I would turn to crisis response. I mean, we've got years of history of crisis response phone lines. One of the things I talked about was the transition to 988 for the suicide prevention hotline. And there's tons of peer-reviewed studies showing their efficacy. Even texts, I mean, the use of text rather than voice telephone, but text, particularly among teens, have actually turned out to be a preferred modality for teens. There's good data around veterans using telephonic services, and again, text reminders regarding appointments or practices or self-care routines. So there's some good evidence for efficacy in a variety of realms.
So great. Thank you all so much. Charles, let me turn it back to you with my thanks.
Thanks, Nick, and thank you to all of our speakers for your great insights. Just a few final notes before we close things off. All attendees will be receiving an email from the network with the video playback of this webinar, as well as a link to our brief webinar survey. That survey takes just 1 minute to fill out and provides us with some really great insights. You'll also be receiving an email from ASLME with information on how to apply for CLE credits for this event. And finally, join us for the 2021 Public Health Law Conference this September in Baltimore. We hope to host the conference in person, but we will be providing updates to our registrants with developments as time goes on. So that concludes today's webinar. Thank you all for attending and have a great rest of your day.